are 13 minutes behind the schedule, so we will continue immediately with live cases. And I was asked to connect first with Homolka Hospital because they are ready for epicardial puncture using carbon dioxide insufflation. So let's go to Homolka. John Silberbauer.
I think Peter wants to start.
Hey guys, it's good morning. So I would really continue fast with introduction because we have no time, because we are waiting for the access and then we need to continue with the case. So we decided to get the persistent AFib patient after one procedure done 2021. So she is like 63-year-old female with persistent AFib since 2020, and complex radiofrequency ablation was done in 2021 with PVI, box lesion, anterior line, CT isthmus. So, but we didn't terminate the AFib that time, and we used the DC termination for this AFib. So she's currently on the bisoprolol, amyl, and dabigatran 150 BID, and actually in October, very early after the first procedure, she got again the palpitations, the dizziness, even like syncopes, and actually evidence of AT, not atrial fibrillation, but was diagnosed AT. So she is pretty much not disease, no significant any comorbidities, and so we decided to get the EnSight X technology for mapping and COT powered, as Dan stated. John is ready. John Silberbauer and Honza Petru are ready for showing you the case, how to access the pericardium. This is only the illustration what we did this 2021. Okay, so John, we can switch to you. Okay, and well, please introduce the case, the status.
We find on the map.
Thanks.
Okay, so we are good.
Good morning. Great. So now we are going to get going with the epicardial access. So the first step is to get the Agilis into the coronary sinus. We can see here that the ablation catheter.
So they don't see it now. Can we have a screen to have our screen X-ray, please, from Homolka?
Let's wait for the X-ray to connect.
Yeah.
The X-ray?
The X-ray.
We don't see the screen. Can we see the screen? Okay, thank you.
Do we take a picture here?
Yeah. So can we do the injection?
Yep.
Okay, Sinne. Okay, go.
Okay. So if we get the JR4 and the microcatheter.
Yep.
So we can see there's a kind of very large posterolateral branch which looks interesting. So I think if we can get down that now, then that's going to be a good option. So here we've got a JR4 5-French diagnostic catheter. Inside that we've preloaded that with a microcatheter. And then inside that we've got a Whisper extra support wire.
So do you want to check in our X-ray?
Go forward with the wire. With the wire.
Okay.
So that comes out first. Okay.
So the wire should be first.
Okay.
Okay.
Okay, that's good. So fix everything.
Mm-hmm.
Okay, go forward with the microcatheter.
Okay.
Maybe go forward with the wire a little bit more. Okay, go forward with the micro. That's good.
Okay, how far?
Now
Okay.
that's perfect. Now I'm going to go forward with the JR4 just to, because the biggest thing here is we're so proximal in the CS army that we could risk everything coming back out. So there's the JR4. That's kind of. I'm just going to flex the agilis down a little bit more there, just to give a slightly better support. Okay, if you take your microcatheter distally.
Okay.
Okay, that's
To the
good.
end? Even more?
That's
Okay.
fine. Then take the wire out.
Okay.
Okay, so that's a floppy wire, which we've used to get to the distal vein. We've used a sort of floppy wire because we don't want to dissect the vein. We're now switching to Confianza Pro 12 wire,
That's
which is a wire used for CTO. And so hopefully this will allow us to perforate the vein. I'm just going to pull back a little bit on the microcatheter just so it's...
Should I go slowly or?
No, you can go quickly.
Okay.
I'm going to pull the microcatheter so it's pointing a bit more. Okay, go. Keep coming. You'll see the wire coming through the sheath. It's coming up now. Keep going.
Okay.
Keep going. Keep going.
Okay, stop it here.
Yeah, push, push,
Push.
push.
Even more.
More.
Okay. Good.
Yeah, keep pushing. Let's have a look.
Okay.
Okay.
We are in.
Yep.
Okay.
Okay, so you fix the wire for me, please. Just pushing the agilis back a little bit. Let's advance the agilis a bit. And the JR4. Oh.
Sorry. So pull back the.
I've had a bit of a disaster, haven't I?
Do you want to do it again?
Yeah, we're going to have to do it again.
Okay. So the catheter?
About that. So
the
let's go to the
catheter is-
floppy wire.
Okay.
Let's go with the ablation.
Okay, ablation catheter. Okay. So I prepare with the floppy wire. Oh,
Yeah,
okay.
exactly. Is that in? Can we see on ice?
Okay, I can help you with the ice if you need. So we are somewhere in the ostium now. Okay. So it wasn't easy to introduce the CS catheter, even ablation catheter. So
No.
maybe we are a little bit struggling, So sorry for that, but this is life, so it can happen. But we are inside now. Okay, that's great.
So we were in a risky branch there, falling out, as I mentioned. I tried to sort of get the support with the JR4,
Okay.
but now we're much higher up. So the agilis won't fall out in this location, which is good.
Okay. So we have the microcatheter and.
Should we do another picture, because we're now higher
Okay,
up?
sorry. Okay.
Yeah. Wait, camel syringe.
Here. Okay.
Actually, we didn't get the catheter that high before.
So another injection. Okay.
Take a picture. Okay. Let's see if we can go higher up, because that's much more stable.
Okay.
Go forward with the
And the floppy wire, yeah?
floppy wire. Yeah.
Okay. So we will see there. Should be first.
Go with the wire.
Okay, wire's coming. So we are in the same branch again. Do you want to cannulate the different one? So we can pull back maybe the
Should we?
Judkins and cannulate the superior branch.
Well, we're here now. Let's
Okay.
just go again.
Okay.
So fix the wire.
Okay.
Microcatheter.
It's coming. Okay, so we are there.
Okay.
Need to go even more
Stay there.
distally. Okay.
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 Yep.
Exchange it.
Yep.
Okay.
So the JR4 is hopefully giving us more support this time round.
So this end or this? I think this one.
No.
Okay. Super.
So when this was first described with the right atrial appendage, they were using the back of the angioplasty wire, but we're trying to be a bit more controlled, hopefully.
Okay. So I'll be there quickly. Is the wire? Can you see it?
Not yet. Just keep
Okay,
going.
coming.
Keep going.
Okay, so I'm
Okay.
at the end.
Go.
Okay, should I perforate?
Yeah. See if you can perforate. Yep.
Okay.
Keep going. Keep going.
Okay. Excellent.
Now you
The maximum.
you fix the wire.
Okay. Great, we are in.
Okay. So. Okay. Good. Right. So take the wire out, please.
Okay.
Okay. So we're
They're
going
out.
across to the right side of the
Okay.
heart. And if you get that 2 mil syringe, let's just put a bit of contrast just to prove that we have,
Okay.
I don't know, not come back through some sort of collateral or something.
Okay. Should I aspirate or directly?
No, just inject.
Injection.
Inject hard.
Okay.
Okay. I think there's no
Very
doubt about that. Right, so if we flush it with the 2 mils of saline,
Okay.
the contrast is very viscous, so you really should, it's easy to flush it through with
Okay, so
saline.
flushing with saline.
Yeah.
Okay.
Okay, and then
So it's full
go
there.
to left lateral.
Okay. Teďka jdeme s tím lidi, jestli byste to drželi. So left lateral position on X-ray.
Go.
Take it. So now we have left lateral, 90 degree, yeah.
Yeah.
Okay.
Okay, and then if you inject there for me, okay, you can see the CO2 coming in.
Excellent.
Blood pressure is 120. Okay, if you give me another one.
Can you show the blood pressure? The screen for blood pressure now?
Can you put another syringe in for me?
Okay.
There
This one.
on the,
Okay.
so we put in about 50, 60 mils now. We're just going to put in a little bit more.
Okay. 60 more.
Is it in?
Is it enough? It's not full, like.
Push it in hard.
Okay. Okay.
Okay,
It's
I-
inside.
Okay.
Okay.
Okay, so I've done a relatively low puncture there because this is for an atrial ablation. With the ventricular ablation, we could have gone higher up.
Okay. This is 6 French if you want.
Yeah. So it really, the tricky bit is obviously the CS bit, but then the epicardial puncture itself becomes extremely straightforward, as you've just seen. Okay, and then what I like to do is just aspirate, just to make sure that there's no blood in there. And we can see, if you can see on the video, the CO2 is now coming out the chest, which has just gone in the leg. So there we go. Take another one out, just to make sure there's no blood. And there's nothing. There's perhaps a little bit of pericardial fluid there, not much. Okay, so that's all fine.
Maybe you can comment on the eyes, but it's not visible on screen, so can you just show for a while how does it look around the left and right ventricle, so there is no, like...
I mean, I've taken the CO2
bleeding,
out, but what I can do quickly for you is put some more in. It's not very obvious on the eyes, is it?
So you put 60 milliliters more.
I've just put another 60 back in.
So it's not visible here.
It's not really visible.
Yeah.
Okay, I'll just take that 60 back out again.
Okay.
Yeah.
Good. So back to this X-ray screen. Yeah. And now we can introduce the edgeless one for pericardial space. Okay. So we were more struggling with perforating from the coronary sinus than to do the puncture.
Well, exactly,
itself.
because the puncture itself becomes extremely straightforward, doesn't it?
Yeah. Really appreciate how fast you were. Okay.
Okay, so if we can go to LAO. So that's it. That's the epicardial access using carbon dioxide. I think it was instructive, really, that I fell out of the vein at the bottom, because that does happen, and I knew I was at risk of that, because the agilis wasn't really sitting very nicely in the coronary venous system. Let's just straighten this out. Now we have an anterior puncture at the moment. Maybe do you want to give me the HD grid, and I can just show quickly how we swing the access around from.
Okay. Napojit HD grid flash, jo, potřebujeme.
From an anterior one to a posterior one, because obviously with atrial ablation you need to be posterior.
Any questions? Because we will switch to another Zoom.
Now,
you have connection for HD grid? Yeah.
Aspirating again. There's nothing in there at all. It's absolutely clear.
There is one question from Congress Hall.
Yeah.
Hi. This is Boris Schmidt. Hansa, John, very nice work, impressive. Just one question: what is the optimal position for the microcatheter? Do you need to bring it anteriorly for the puncture, or can you leave it wherever in the pericardial space before you inject the CO2? And the second question is, what is the optimal time point to take it out of the coronary sinus?
Yeah, two great questions. So for the first one, it doesn't matter unless you've got a loculated adhesion situation. So there have been a couple of cases where we've sort of punctured out posteriorly, and I've been a bit concerned, but they've had a lot of adhesions about putting CO2 in, about potentially causing a tamponade that was inaccessible to drainage. But in the absence of that sort of scenario, it makes no difference what vein you puncture out of. It could even be an atrial vein, for that matter. Because the CO2 will just simply rise to the front, and as you've seen in left lateral, that's easily visible. Sorry, what was the second question?
When do you take it out during the procedure, the microcatheter, because you want to avoid bleeding, right? Or
I don't know if you can see the syringe. Can you see the syringe? So it's just got clear pericardial fluid in there right now. Okay, there's no blood at all. I'm going to now pull everything out the coronary sinus. Remember, that's actually our second puncture, because we punctured with the first one as well. Mm-hmm. So the first puncture with the wire didn't cause any bleeding. We know that, right? Because there's no blood there now. I should have made a small hole now with the microcatheter, which is just 2 and a bit French. But in actual fact, at this point, there's still no bleeding.
Yeah, no blood.
Okay, I'm aspirating. We might see a little bit later on, but I mean, for me, I'd be good to go and do the transeptal now and give heparin. Mm-hmm. So
do you want to introduce the cath? HG grade into
so just
pericardial space?
Before we do that, I just want to show you, because normally we're doing ventricular ablation, obviously, but this is an AF case. So, can I go to AP?
Frederick Sacher, John, great job. What about anticoagulation? Do you stop them before, or you go with continuous anticoagulation?
So we've been doing these cases, Fred, with uninterrupted DOAC. And one of the reasons, so the first thing is they don't bleed. And the second thing is we, in the UK are under pressure to get people out of hospital fairly quickly. So we're looking to discharge them either that day or the following morning. And it's more comfortable if they're on uninterrupted DOAC than if they're sort of starting it either just before they go home or even when they do go home. So,
all right.
So here we have
now we will leave the Homolka, and you will have the chance to be online for next maybe 10 minutes at the end of this session, and we will switch to ECAM for VT ablation of ischemic VT ablation using DiamondTemp.
Okay.
Okay, thank you.
See you later.
As we agreed. Okay, so do you see us? Is this EP lab number 3? Tarvinder Dhanjal and Petr Peichl. Do you hear us?
Yeah, we can.
Hello.
Hi. Yeah, I can hear you. We can see you.
Perfect. So just very briefly again, the patient, it's very similar what we had here yesterday. It's this time an elderly guy, 73-year-old, but again very large anterior aneurysm, which I will show you on MRI later on. Ejection fraction is on MRI 30 to 35. On the recent echo was lower. Depending how you quantify that. The main reason why he's here is the repeated shocks and repeated slower VTs below detection rate, and also he has a paroxysmal atrial fibrillation, but we decided not to deal with that today because it's a large aneurysm. He's on amiodarone already. So this is the guy. If you make a next slide, you see the anterior aneurysm on ECG, absence of the R waves, and the ST elevations, persistence, consistent with aneurysm. Can we go next slide? Which shows you the MRI 2 years ago. I see very thinning of the wall, of the anterior wall, a quite large one, I would say, apical aneurysm with anterior septal wall. If you go next slide, as a different, this is all the tracings we had from the ICD. We don't have an intracardiac, but this is because he came to the other hospital. But generally, you see that the tachycardia cycle varies from 400 milliseconds to 350 milliseconds. Some underneath the therapy, which was lower after this, but this was December, and so we have here. And we started in general anesthesia. We have intracardiac echo, RV pacing lead that we're using primary transeptal access. We just have a very thin 5-French sheet for blood pressure monitoring. And so far, the patient required only a small amount of inotropes, despite the low ejection fraction. So maybe Torf, you take over.
Thank you, Peter. So we started with a sinus rhythm substrate map. Can we see that, please? The sinus rhythm substrate map. And
can we show Navix?
Can we see that? Okay. Excellent. And you can see that the large dense area of scar at the apex with border zone, considerable low voltage regions extending around that. The green tags are where we have manually tagged, decrementing.
Can we take off the ablation side points because we already did something, but it's easy to do, or if so please take it out because then maybe more kind of systematic.
Yeah, we've got a lot to show you because we've got 2 VTs, VT activation maps, ablation post RF substrate map as well, so quite a bit to get through. So you can see on the review screen, can we go to Deep 1, please? Deep 1.
Can you go Pruka review screen?
And change the sweep speed, go back. Beautiful. So if you can see on the review screen, you can see a sinus beat followed by 2 S1 intervals, 600, 600, and the S2 is at 380 milliseconds. We chose 380 milliseconds because, interestingly, that was the VARP plus 20, and it was also the VT cycle length. You can see that in the sinus beat, there's minimal fractionation on the white spline at the end on D1, D2. And with both S1 beats, there is decrement from the sinus beat, But with the S2 at 380 milliseconds, you see considerable decrement in the D spline, the white spline, but you see this differential decrement that we talked about yesterday in the A spline, the green signals. The green signals decrement considerably more than the D spline. So you've got A spline decrementing more than the D spline. And this differential decrement is the prerequisite to unidirectional block. If we go to deep 2, another example of decrementing signals on the yellow spline, you can see those late potentials. The S1 to S2 interval is greater than 20 milliseconds. And this is our recent Europace paper that's in press, that we've shown that 20 milliseconds is the optimal sensitivity specificity cutoff with this approach. If you go to deep 3, again, we had lots of fun this morning, actually. Lots of deep signals. In the sinus beat, we see no fractionation at the end of the QRS, but you see some fractionation in the sinus beat just before the far field signal on the sinus beat. And when you put the S1s in and the S2, you see initial decrement and increasing decrement with the S2. For deep 4, again, lots of examples of this. Increasing decrement with the S2, deep 5, and deep 6. Now, this is interesting. If we have a look at this, you will see that there is no decrement, although the near field signal with the S2 is delayed from the far field signal. If you compare the S1 and the S2, so if we measure those EGMs, can we measure the EGM duration of the S1?
Můžeme změřit od stimulu k trvání HD gridu na konec. Okay,
so that's the stim to near field. We don't really advocate looking at stim to near field because we're not really that interested in the latency, the stim to the far field signal. But if you measure that and the S2, you'll see that there's very little difference, less than 20 milliseconds. So this is the non-decremental site. It showed deep 7. And again, we see this differential decrement. In the A spline with the S2, you see a considerable decrement of more than 100 milliseconds on the S2, the last extra. And if you, all the way, keep going. Keep going. Okay, a bit too far. But, yeah. Anyway, you get the idea that there is increasing decrement with the S2, which is more than the decrement that's occurred on the white splines, on the D spline. So as we were mapping, we induced spontaneous VT. I'll hand over to Peter to talk about the VTs.
Just because we mark it on a review screen. So if you go more, maybe for the first one, we mark it. So there would be the first number first. So there was some irritation, then there was this arrhythmia. Can we go 12-lead ECG in the review screen? So generally, if you look at this 12-lead ECG, so it's a more apical QS from V1 to V6. It's it's negative in 2,3 AVF positive, so inferoseptal apical maybe origin. But what do you look for if there is a multi-electrode mapping? Can we go for the intracardiac electrograms? Is these beautiful mid-diastolic potentials that really cover the whole, I would say, mid-diastole. We did also the entrainment there, so can we go for the number 2, which maybe slow down a bit to really see that you see it's capturing not at the exit, but maybe mid or maybe close to the entrance because you have a long SQRS, and you can also measure the post-pacing interval. You have to measure the cycle length after, not prior, please. Okay, so now it's just if you move it to the stimulus, can we move this one to the stimulus? Okay, so it's a little bit longer, but you got the idea that you're probably very close with this one. So can we go into number 3? We started because the patient was tolerating the arrhythmia. Okay, number 4. Maybe if you can increase the speed, so maybe you can appreciate in the ablation. This mid-diastolic signal, can we unclip it? Okay, so maybe you can see that there is a mid-diastolic potential, and we finally got there, and when we start to ablate there, can we go to number 5 and slow down, even more. And if you go 12-lead ECG, maybe that would be the perfect one. So we start immediately the mid-diastolic potential. We have some intermediate change in the morphology. Can we keep the 12-lead ECG and then the tachycardia organized to something else, which has completely opposite to 3AVF and access? So then we go to number 6. Can we go to number 6? And we go intracardiac. So this is the morphology. Can we go to the number 7, which should also show the intracardiac? So we went back to the HD grid, and you can just to localize the mid-diastolic activity. Obviously, you can see that, and that was activate. This is the kind of activation mid-diastolic, more discrete potential after some ablations was done. I forgot to mention the EnSite map, so maybe Tarv can comment on the VT1 activation map.
So Callum, can we pull up this is the VT1 activation map. Now, the annotation here has been based on the near-field version 2 software. So you can see, first of all, on the annotation on the EGMs, that the high-frequency components have been annotated correctly. This is really nice to see. The far-field large EGMs within the QRS of the VT have not been annotated. So this makes it a really slick, quick process for accurate VT activation mapping. If I always prefer the black and white. I don't know why. So if we can yeah, so my eyes see the black and white isthmus nicer, and you can see, I can't point, but you can see the area where the mouse is, the reentrant circuit coming down the isthmus and back up. Nice slow conduction. And if we go to the VT2, so during ablation of the isthmus where the triangle was flashing, we terminated that V. Immediately a second VT was induced. We flipped to the HD grid, did another quick remap, and here the exit site was more anterior lateral. And you can see we have a figure of 8 coming down and then back up a very narrow isthmus.
With this mid-diastolic activity which you have seen on the review screen.
Callum, can you just pull up some of the electrograms of those mid-diastolics? So where the conduction, there, beautiful. So again, you see the near field being tagged correctly with the version 2 software upgrade. This makes annotation really accurate. So as we were mapping this with the HD grid, at the anterolateral region, the exit site, can we show the bump termination of the VT?
So can we go to review screen for the
yeah. So
review screen.
That's it. So you can see there we bump terminated VT. So the ablation strategy was to target 2 things. 1, the entire VT isthmus, as Delabella has shown nicely. If we can target both the mid, the exit, and the entrance parts, we will be successful. What's interesting with VT2 is that you can see there's a big pseudo-delta. So the exit is probably epicardial, but as long as we can get some component, because we know that about 80% of the isthmus in post-MIVT will involve the endocardial surface at some point. So if we target the entire isthmus, we've got more of a chance of successfully being able to break this reentrant circuit. So we ablated the entire isthmus of both VTs, and we targeted the second thing, substrate, which is the deep signals. So wherever we've got the manually tagged green dots, we've ablated those. Ablation time, I think we've done about 25 minutes of RF.
Can we check? Maybe we can also show the ablation. So can we go for a review screen and make this plot window?
So the ablation catheter we use
go for 42. Okay.
Is the DiamondTemp ablation catheter. So the DiamondTemp ablation catheter is temperature irrigated RF, high power, but the RF is tailored depending on the temperature. So this is temperature regulated power titrated RF. The catheter has a black diamond tip, chemical vapor deposit diamond tip, with 6 externalized thermocouples that allow for rapid 50 milliseconds. Every 50 milliseconds, the temperature is sensed and the power is adjusted appropriately. And what you can see on the review screen, if we can flip to the...
Can we go for the review Pruka screen? Maybe that would be better for people to understand.
Yeah.
Perfect. And then, okay,
So, no, you did have it before.
yeah, just hold on. They just, okay. It's there.
Yeah, beautiful. So if you look on the right-hand side graphs, you will see the power initially ramps up to 50 watts, and then you can see the power is then brought down and maintaining the bottom graph, which is the temperature, at 60 degrees. So we're setting 60 degrees, and soon as we reach 60 degrees, the power has been ramped down immediately to give you the right power for the right lesion. We can see that we aim for about 15 ohm impedance drops. My group has published the first series of VT, structural heart disease, VT ablation using this catheter. This was published earlier last year, and we finished recruitment for TRACK VT now with the help of 4 other European centers. And we've been refining our ablation strategy because we've done some ex vivo canine work with the Minnesota group in the US. And we've shown that as soon as we reach 60 degrees centigrade, ablation beyond 20 seconds does not buy you any more depth. So the protocol that we've been using is to get to 60 degrees centigrade. That may take 4 or 5 seconds with good contact, and then we don't ablate for more than 20 seconds. It's absolutely fantastic here in the lab because we've got ice and we've been able to look for whitening of the tissue. And generally, when we've reached that 20-second point, that's when we've started to see the tissue whitening. And we certainly haven't had any steam pops. So we've ablated, and we've now done a remap. We've just finished doing a substrate remap, which we can show, please.
Just a small comment about this echo-guided or ice-guided approach for the ablation. Generally, we aim to have a very little of those whitening, which means microbubbles into tissue, because there is a kind of continuum then to having a steam pops. This DiamondTemp is a way how to do these high-power lesions, I would say, safer, because you generally look for the impedance drop. You just look for the temperature, target temperature. Once you reach the 60 degrees, you can just follow for 20 seconds maybe, and then you stop. And that worked perfectly. We saw very nice, I would say, good profile in terms of this whitening, because still you use 50 watts, it's go really rapidly. It's very, I would say, effective, but it's also on the safe. So these thermocouples on the DiamondTemp gives you more safety, kind of, not hopefully feeling, but also real, which could be demonstrated in the studies, that it provides a better lesions which are not overcooked, I would say.
This is the remap that you can see, and you can see that the areas where we've wanted ablated successfully, the substrate has been eliminated. We've re-performed deep mapping in the areas where we'd shadowed the grid, to see if there are any deep signals still there. And we can show on the review screen post-deep mapping on the Pruka, please.
Maybe we can show also online screen. Okay, so let's go to post, yeah.
And you can see there where we saw considerable decrementing potentials. With the S2 now, there's nothing. We can try and show you that live.
Can we switch to Pruka live? So generally we moved somewhere to where the green dots were.
Okay, great. So this area here, we saw loads of decrementing potentials, and this was part of the VT1 isthmus. So if we put the 600, 600, 380 here, please. And we're pacing from the RV apex. Beautiful.
Maybe we can pace also from the HD grid now with the 5 to 10 somewhere. Can you just see whether it's a capture?
So 10 milliamps.
Is there any question from the audience?
To nemusí být cenzovaný.
No question?
So we're just looking to see if we can pace capture from the scar zone where
there's no capture also, so that's a seems to be
no capture.
I believe there is a local capture. Maybe if you believe, můžeme to na to podívat na ty signály, because there was some dissociated activity when you tried. If you move, it seemed to be some. Can you increase the sweep speed? Increase it. Oh, okay. It's not that convincing, because okay. So.
I mean, I can see what you're saying, Peter, because there is some fractionation after the stimulus on
Can you go review screen, maybe, if you
on
believe
the
me?
B-spline.
Yeah.
On the B-spline. Yeah, I
so
think
maybe
you're right.
if he pays from the far away from the, so like A12, just to have a kind of far away to maybe able to see something from the, and now it starts to pay. So maybe there is something more to do.
Yeah.
But generally there was no decremental, we don't know really what to capture. Sorry, just wanted to demonstrate something.
Perfect, that's beautiful, absolutely. Any comments or questions from the audience?
Yes, there are a couple of questions. Please. You.
Hi, Michał Farkowski, Warsaw. Great case. Thank you very much. Could you tell us, there are a lot of target points around the scar, but you highlighted the isthmus pretty neatly at the very beginning. What are those other targets that you did all around the scar? There's a lot of lesions.
Yeah, that's a really good question. Yeah, in our lab, we ablate two things for VT. One is the entire VT isthmus, and two are all the deep potentials. That's it. The green tags are the deep potentials.
So generally the plan now maybe is are there more questions?
Yes, there is one more. Elad, please.
Yes, hi Peter and Tarv. Excellent case, really inspiring. I have a question. Your pacing protocol is from the RV Apex, right? Are you sensitive to look for decremental conduction from this wavefront that activates the LV? I'm just wondering, and it significantly narrowed your target, so that's beautiful, but I'm just wondering if you, in some cases, also supplemented your pacing protocol from a different wavefront to see if there is any decrement conduction that is preferential from one wavefront versus the other.
Elad, thank you for that question, and it's a beautiful question. So we've just had our deep mapping study accepted for publication in Europace, and that was certainly one of the reviewers' comments, which was to potentially explore inducing decrement from other sites. Now, there is some basic science research that does show that what is more relevant to seeing decrement within a localized region is the conduction time, the speed of the wavefront arriving. The directionality of the wavefront, the hypothesis is that it wouldn't really alter the deep maps considerably. Now, I can't show you true deep maps because no mapping system can create automated deep maps. But Elad, if we did have a mapping system that could create automated deep maps, that would be a study that we could do very easily, which would be to pace from multiple sites and see if the deep map was altered. And that's something that we're hoping to do. One study that has potentially tried to address this was the BART sense pacing protocol. So in the BART sense pacing protocol, they actually activated the scar not only with a different coupling interval, the VERP plus 20, but also from a different direction to how the scar was being activated from the sinus beat. So with single sensed extras, they changed both the coupling interval of scar depolarization, but they also changed the wavefront directionality of that scar depolarization. So it is something, Elad, that it's a brilliant question, and it is something that we do need to explore, my friend.
All right, if there are no more questions, you consume 22 minutes and you will have chance to be online again for 5 to maximum 10 minutes at the end of the session. And I just gave the information that we should switch to Milano for online
case.
But
just very few, maybe Tarv can comment what's the plan now to remap and maybe reinduce.
Yeah,
that will be the...
Absolutely, Peter. So what we'll do is we'll do a sinus rhythm substrate map. We'll look for more decremented potentials. Hopefully we've targeted all of them or most of them. I am slightly concerned with VT2 because it had a pseudo delta. So we just want to make sure that VT2, whether I'm not sure whether we've had transmurality with the lesions, but hopefully we've had lesion depths that have eliminated at least part of the VT2 isthmus. So we started the case at 8:30. It's coming up to 10:30, so we've still got a bit of time. Okay, great.
Okay.
Shall we carry on remapping? Okay, let's carry on remapping then, guys.
Case. As you know, Brugada is a benign disease, but unfortunately this patient arrived to us in cardiac arrest. And then he had other episode of cardiac arrest. He has a family history of cardiac arrest. So let's transfer the connection to Gabriele and Giuseppe.
Hello? Can you hear us?
Gabriele.
Yeah, we are here. We are ready to start. Giuseppe will introduce quickly the case.
Okay, good morning, everyone. If I can have a couple of slides here to introduce the case, it will be very quick.
Bye.
So, next slide. This is a 47-year-old gentleman. He had no family history of sudden death. He presented in September 2020 with aborted cardiac arrest, and this is the reason why he was admitted to the emergency room. Next slide. At that time, he showed this ECG. You see in the left panel, you can see the standard precordial lead placement. So you see a V1 and V2 with a suspicious pattern. And moving upwards to the high right precordial leads, we can appreciate a very suspicious pattern. So for this reason, at that time, it was admitted to our department to schedule him for an Eichmann test. However, when he came to in our lab, next slide, he showed a spontaneous pattern. And this is clear. You see V1 to V6 actually are V1 and V2 in the second, third, and fourth intercostal spaces. You see clearly spontaneous type 1 from V1 to V4. So pretty large area we expect of abnormalities. So we didn't perform the Eichmann test, considering the story we implanted a subcutaneous ICD, which shocked several years after. You can see the next slide with the appropriate therapy in the subcutaneous ICD. So due to the high-risk profile, we are here performing epicardial mapping. If you can move the connection to the lab here, you can see the big screen, the Odyssey screen. So we have already performed the endocardial map of the right ventricle, which is showing a fairly normal substrate without abnormalities and with a normal voltage. So here, Gabriele, move to Gabriele for the epicardial puncture.
Okay, we go. This is a rather more simplified approach, as you see. We try to go anterior, because in this procedure it's important to be anterior. I think I am too much anterior, so I will be more posterior. Okay, I am in. I think we have a nice anterior puncture. Okay, and we start.
Okay, now we prepare here.
Okay, we have to dilate progressively before going in with the Agilis epicardial sheath.
He did the endocardial map, and it is a very important anatomical landmark for mapping the epicardial aspect of the myocardium. Can we see the endocardial map? Can we see all the screen? Okay. This is the endocardial map. Can I see the local activation time and the voltage map? This is the voltage map, and this is the local activation time. Can I see again the voltage map?
Let me aspirate.
Okay. Can I see the PDM, the potential duration map?
We have a clear puncture. and now we put in the decanav for mapping.
Yeah. So, too long procedure, Gabriele.
Yeah.
More than 1 minute. Why?
Yeah, okay, it's anterior, good.
It's important to be anterior because in most of the cases, the substrate percent is localized on the anterior aspect of outflow tract and anterior wall. So it's much easier to navigate having the catheter in the anterior aspect. In this moment is in the anterior wall, and Gabriele is pushing a little water into the pericardium to better navigate. In this moment is important to navigate in the pericardial space in a smooth way. Do not push in case of obstacle. We inject a little water to have a freely movements. Now is navigating at the border of right atrium. Now is in the outflow tract. This is inferior part of right ventricle. Can I have the fluoro so you can see? How is the water from the pericardium, Gabriele?
Clear.
Clear, okay.
No, this is the first thing that we checked.
But you see the potential are pretty short. We don't see any abnormal activity in the left ventricle. In this moment, the catheter is at the border between left ventricle and right ventricle. In the left ventricle, the electrogram is very narrow. So, Giuseppe, okay, Gabriele, let's concentrate on the outflow tract and the anterior wall. We have a little prolongation of the electrogram, but nothing special. Can we amplify the EKG to better see the electrogram? Because this is the demonstration of correspondence between electrogram and the EKG.
Well, Carlo.
Yes, tell me.
To be clear, I think the potentials here are not completely normal.
Yeah, not completely. But Gabriele, as you know, this patient had the cardiac arrest in the emergency, and the immediate EKG after the cardiac arrest was without type 1. This is just to clarify that we emphasize the importance of type 1 to predict the cardiac arrest or as condition to have cardiac arrest, but this is an example of a lack of type 1 at the moment of cardiac arrest. But doing the mapping in this moment, you clearly are showing that the substrate anatomically is completely normal because the voltage map, can I see the voltage map, Benjamin, of this initial epicardial map? The voltage map, can I see? Okay. Dimmi, Gabriele.
Maybe we need to point out that even in spontaneous type 1, when we induce general anesthesia, which is necessary for this procedure, very frequently the ECG normalizes. So we don't really expect to have a full-blown substrate under general anesthesia.
Yeah, but see now the voltage, the bipolar map in this patient seems to be pretty normal.
Yeah.
Just we need to refine the map, but I don't see big issues in terms of anatomical abnormalities.
No.
In fact, although a lot of people say that Brugada has fibrosis, in 100% of the cases, we have to disagree because in our experience, the Brugada substrate seems to be pretty normal, but functionally abnormal. Okay, can we start the Ashmalin? Can you zoom the EKG? I want to see the EKG during the Ashmalin infusion and to see the changes in the substrate. Okay. Zoom more, little more, okay. But I want to see also the map. EKG and map, Benjamin. Both.
Let's see the full screen.
Full screen. Okay. So did you see the black dots, the engineer depicted on the map? Those regions are the region with a little prolongation of the electrogram. Can we see in detail on the black dot the aspect of the electrogram, just to confirm that is black because it's really black?
Yeah, we are on it.
Okay. Okay. So we have a little prolongation of the electrogram, not really pathologic. As Gabriele said, at the beginning of the procedure, the general anesthesia, in particular the propofol, can reduce the pattern. Okay, can you move the catheter on the left ventricle to see the difference at the baseline between right and left ventricle? See, in the left ventricle, we have a very narrow electrogram, clearly narrower than the electrogram in the right ventricle. Did you start the Eichmann?
Yes, we did.
Okay, go on the outflow tract. Go on the outflow tract. Because the black dots are depicted mainly on the anterior wall, but I think we have the substrate also in the outflow tract. Gabriele, go on the outflow tract. I want to see the time lapse of the electrogram during the Eichmann. I want to see the time lapse. Stay there, and we see how the electrogram change. Usually we have the changes in the epicardial electrogram just before the modification of the V1, V2, and V3 EKG. Can you zoom a little more the EKG?
Carlo,
yeah, tell me.
I have the impression that we are already having some prolongation of the signals.
Yeah, don't be in a hurry, because we need what you see. Okay, now we have the prolongation. Let me see the electrogram. Why you go out? Okay, we start having the prolongation, but we have a very small potential at the prolongation, but we started having the prolongation of the electrogram. At the EKG, we see the pattern type 1. How much Eichmann you gave? Quanto ne avete dato?
We are up to 30.
Okay, we're up to 30. See, now the electrogram is prolonging. Can you zoom this electrogram? So very interesting. The substrate is very dynamic. See, at the beginning it was very narrow. Now it's prolonging. Usually we should be happy of this electrogram prolongation, because during general anesthesia, if we further infuse Eichmann, we have the risk to create a monster, and I should stop. We stop the Eichmann. It's sufficient just to infuse 25 milligrams. And we have a huge prolongation. The line should be further, Benjamin. We have a low voltage potential. Be there. So did you see in time lapse we had the dramatic prolongation of the potential? See, the potential starts in the outflow tract. Gabriele, move the catheter in the outflow tract with the distal electrodes. That is an artifact. Be there, very stable. Be stable, stable, stable. I hope in the near future to use a catheter like HD Grid, because it will be much faster. Benjamin, can you tell about the potential, how prolonged they are?
Yes. Which microphone?
Yeah, okay, we hear you.
Okay. So these are the potential that we're looking for and we got a case. We can see that the region we have up to 340 millisecond potentials.
Huge. Huge. This is a huge potential. And see the EKG in this moment, zoom the EKG, is a monster, see? This is really a monster. And at the beginning it was pretty normal. But was already clearly visible, the little prolongation. This is obviously due to the experience after 1,000 cases. Go on the map again. Go on the map. Vai sulla mappa. Oh. Okay, do the refinement on the right atrium. That is red, not purple.
Yes, I need to recheck some points.
Yeah. This area is not defined. Is just a preview of the area involved in the Brugada. This is normal. Everything is red there in 1, 2, 3, 4. Everything is red. Everything is red. Remove the cath, Gabriele, otherwise you do the artifact. Pull back a little bit, okay. Stay there, okay.
Carlo.
Important is to...
Carlo, can we see also something from the left ventricle? Because it's very interesting. This ECG is up to V6, okay. Very high elevation.
We are defining the border of the normal muscle. Ma perché stai lì col catetere? Muoviti, vai lì sul tratto di efflusso e sul bordo del ventricolo sinistro. Okay, this is the border of left ventricle. It's extremely important to define the region between right ventricle and left ventricle. Vai sull'interventricolare anteriore. Okay, this is the border between interventricular artery. This is left ventricle. Now the cath is on the left ventricle and everything. Fateci vedere l'elettrogramma anche. L'elettrogramma.
Okay, thank you.
Oh. Go at the border in the interventricular artery. Everything is red in the left ventricle is normal. But I think, okay, go at the border of coronary artery. This is extremely important because to avoid the ablation of the coronary artery region is essential because the risk of inducing myocardial infarct or coronary artery spasm is one of the risks, but we never had complications due to this. I don't have any interest in the left ventricle now, Gabriele, because clearly the subset is on the right ventricle. And the type 1 EKG is still persisting. Usually the effect of Eichmann is 5 minutes. In this case, we are having, just in this moment, the reduction of the effect. Can you zoom the EKG to see the reduction of the effect? Fai un zoom sull'ECG. Okay, little reduction in V1, V4, and in V4, V1 and V4. Okay, let's go again on the map. Just to know, the purple area in terms of voltage, can I see the voltage of purple area? Show the bipolar map of purple area. Just to show the difference between long QT and Brugada. Brugada has a normal tissue without any voltage issue. Vai, prendi un po' di punti. Let's do. Okay. Okay. It's just a question of the refining of the map, but we don't see any fibrosis, any red area. And that blue and green is due to the contact of the small electrodes to the tissue. If we go on those zones, we can clearly see that the electrogram is pretty normal. You can see the electrogram pretty normal in that region. So let's go to the PDM again, and when we finish, we do again. But what I have to tell you, during Eichmann, we can have a little reduction in the voltage, little, but not due to the abnormalities of the tissue. Let's define better the septal region, okay? Gabriele, can you try in the outflow tract close to the pulmonary artery to see if you detect everything? See there, we have a little more prolongation near the pulmonary artery.
3-4 is positive, Beniamino. 3-4 is positive.
Okay, I heard that they would give the line to another hospital. Okay, after the map, we start the ablation and you connect when we are ready for the ablation and the normalization of the EKG. Okay? Now we change the catheter. We introduce the ablation catheter. We define the area. Okay, let's connect when you can. We continue the procedure and we will show the EKG after the ablation and the electrogram after the ablation.
All right, we will come back in half an hour, maybe more.
Okay, we did finish at that time.
We will switch to ECAM just now for the last case today.
Katja?
Yeah?
They want to show something.
Okay.
Můžete tam dát teda tu prezentaci toho pacienta. I will introduce the patient.
Yeah.
I will say something a little, but you can finish.
Yeah.
Hello?
Yes. Yeah, I can see you. You
are
online.
Can you also hear us?
Yeah, we can.
I was told that since I have this respirator, my voice is damped, but so I will try to speak aloud. So we had a patient who was designed as ischemic because the patient had, in 2008, he had cardiac arrest. Can we go one slide more? No, not. Okay, second slide, please. And he had cardiac arrest due to VF. He was diagnosed with non-STEMI, but he was in 2011. He had coronary angiography, he had multivessel disease, truly LAD severely was occluded and with some retrograde flow, and marginal branch was severely stenotic, so he had cabbage. And he was all the time labeled as a 35% ejection fraction. He was implanted with ICD, and this patient came now for ablation because he had some episodes of tachycardia, which was sometimes terminating spontaneously, sometimes there was some feeling that it's terminated by ATP, if we can see here. But you can see that there is a tremendous variation of the cycle length. And the patient was symptomatic. So that was the reason why we decided to go for ablation. Since he is relatively young, so we did not want to give him amiodarone just as a first go. So that's it. And when the patient came to the hospital now, our echocardiographists described ejection fraction like normal. So we were considering yesterday with Peter whether to do this patient. We said it's difficult to see into him because he's very big. So maybe she was wrong, and he had myocardial infarction, and he had some, let's say, therapies from ICD. So let's go for it. And Katja will describe to you what we've done until now. So the idea was to do some substrate based ablation in general anesthesia, so using only single catheter for mapping and ablation, which is Navistar, cool tip without any contact force sensor. and using intracardiac echo. So maybe I can show you intracardiac echo first, and then Katja will explain everything. So this is a view from right ventricle where you see that there is something like epicardial, but that might be after previous surgery.
Is it on the monitor right now?
Can you see intracardiac echo? Okay, I saw that they will switch it.
Now we
okay, so you see here, there is a good function of the ventricle, rather hypertrophic ventricle. There is something epicardial, but that might be after surgery. We felt that there might be something in the septum, but not really. There is a bit bulging of the septum, but not real scar. And if you go, this is anterolateral papillary muscle. In posteromedial, there might be some small fibrosis on one of the, or two heads actually, but small fibrosis, but nothing special. And if I show you aortic root, there are 3 cusps, and really maybe I saw in some area a little bit of, like here, there might be some peri-aortic fibrosis, this whitish area, and that seems to correspond to our finding. And Petr Šťavnický did, before we started mapping, he did program stimulation from left and right, and he was not able to induce any sustained VT. But if we can show, please, the recording of this non-sustained VT, that is, can you show 12-lead ECG on this non-sustained VT during the first induction? First induction, this one. You see variation in cycle length. It's very basal, very in subaortic region, I would say. And there is variation in cycle length, and it was non-sustained. This is the only thing we could induce, and it seems to correspond with some variations to this recordings from ICD. So now Katja will explain you more.
So what we actually seeing this morphology, we were more thinking about something in the subaortic area, so that actually this more LV summit towards the right coronary cusp. But we still started because there was this acute event, and we have reviewed the angiogram, really severe cerebral disease, to look if there's additional substrate, and started just with a typical voltage map. And you see that on the probably you can see the CATO for a second. Can you see it on the big screen? Yeah, you can see. So this is now 3.0 millivolt, bipolar voltage with a standard catheter as a cutoff. There are probably a few non-contact points, but otherwise it's pretty much normal, with the exception of the subaortic region towards the mitral continuity. This is actually where we saw this is also quite reasonable with a induced non-sustained VT, with a variation also in morphology and cycling. So, and in this area actually we found some very nice abnormal electrograms, and probably can show a couple of these.
You can show on screen static screen electrograms review. Yeah, you see during extra stimulation you see this fragmented lower amplitude, and sometimes there were even some fragmented potentials in without stimulation. So this is the only abnormal region, so to speak.
I think there were, towards the aortic roots, there were a couple of more really highly fragmented signals.
In the right cusp.
Just below, where it is
below and in the right cusp, there were also small area with very fragmented signals. And in the apex, we can show the apex. There is a tiny area of fragmented potentials with a little bit lower amplitude, but not significantly. And there is no delay if you pace. There is nothing if you do this extra stimulation from the right. So it's basically just a very tiny scar probably there. So it is nothing to modify. So.
Yeah, so we actually conclude this is probably a second pathology, nothing to do with the coronary artery disease, and a quite, in our opinion, quite typical subaortic scar. And this is his non-sustained behavior also, but if the patient has trouble or has complaints, so probably it's reasonable just to target this very small area just below, just in the vicinity of the right coronary cusp. We are away from the conduction system there, because a little bit more towards the outer mitral continuity, so I think it's quite reasonable to target this area and even can test if we can re-induce the non-sustained VTs.
Yeah, we had also, if you look at perimitral area, and if we elevate the map, you can see it. In this posteroseptal space, you have these fragmented signals, these pink dots. This is posteroseptal space, and there is a little prolonged stimulus to QRS, but it's less than 40 milliseconds, and there are some fragmentation. So it looks like kind of perimitral scar, which is very limited, but mostly expressed subaortic, and it's like a secondary. It's not related to coronary artery disease, so it's kind of cardiomyopathy. But certainly the patient does not have any aneurysm, does not have a clear scar, even subendocardial after myocardial infarction. It was also non-STEMI at that time, so there was no STEMI during his history. And so this is what we've done with point-by-point mapping, no high-density mapping, but I don't think it will help us to use high density. It would only create a lot of ectopy, and even with this mapping there was a lot of ectopy because it's a bit hypertrophic ventricle. So you want to add something more?
I think it's
any questions or comments?
There is one question from Bill Stevenson.
Yeah, very interesting. Does the pacing up in the periaortic area with the abnormal signals resemble the QRS morphology of the induced arrhythmia?
Yes.
So this is a very good point, Bill. It's quite interesting. So if you pace a little bit more towards the septum, you resemble the precordial leads, but we were not able to really resemble the limb leads. So in almost all the pacing sites, you still had a biphasic in one, so not this positive deflection. But we had a good pacement for the remaining leads. But we also paced in the aortic root because there were also some very nice signals in the right coronary cuspis without fragmentation, but we could never get the VT, which actually also changed in morphology during the non-sustained train.
So the idea is to modify this subaortic region because it goes in between right and left cusp, exactly in this triangle. So you see it, this triangular shape. So that's exactly there. So we will modify this, and we may ablate these fragmented potentials in right cusp because that's very related, and that's it. We will try to induce, if we can induce again at the end, this non-sustained VT. It looks like either very small circuit or might be even focal because it's really changing the cycle length and it's non-sustained. So this is our conclusion, and of course we expected to show you nice scar and strategy of let's say unmasking some functional substrate, but it was not the case. So if you have no questions, we will do ablation, and maybe if you then come for 1 minute, we can show you the results. Or if you are you Joseph, still continuing in other places, or
Joseph, what do you think to try inducibility with a little bit of isoproterenol? If it is an automatic VT, what do you think? Is it possible? Little bit.
Isoproterenol. Okay. Tak můžeme dát izoprenalin.
We can move to the. We can.
Yeah. In the meantime, we will go for Homolka Hospital for the last case, and we'll be back in half an hour, let's say.
Okay. Hey guys, so we have right now the second case from Homolka, which is ischemic VT patient, and it's done by, or they are still working on the heart. Toshe Funasako, Honza and me, Honza Škoda and me. And this is a really interesting case because he came as a stable patient with ischemic VT. He got myocardial infarction very, very long time ago, like 1992, 1990. And actually, it was cardiac arrest during the first myocardial infarction. He survived that. And actually, he was cut just recently, this February or March. And no wonder, it's like complete occlusion of LAD with huge epicardial aneurysm and anterior wall dyskinesis and septal akinesis. So his ejection fraction is 25% with LBB and moderate mitral reg. And the problem is that he got monomorphic VT, and that's why he came here for cath. And then we decided, let's go, actually it was terminated easily, and then he got CRTD because of 150 millisecond LBB QRS duration. So now, after CRTD, we plan like elective VT ablation. So here is his baseline EKG. So this is QRS like 140, 150. It's great to see this QS in the full anterior wall. And this is the tracing from his monomorphic VT he came with, okay? He was tolerated this VT, which was just like around like 400 milliseconds. As a part of the study, we decided, because he was like electively indicated, so no storming, okay, no storming. So we decided to implement him, or to include him into the, deep freezing cryocure study, which is VT ablation plus deep freezing, using Adagio, the Adagio system with really deep freezing. What does it mean, deep freezing? It's minus 96 in the liquid in the system, going to the catheter max minus 178, and it's freezing there in the catheter, which is visible here with very nicely steerability. Actually, the first version of the catheter, first generation, was not so optimal. Now we are using much better deflection, actually, and this element is 8 electrodes in the end, within the 15 millimeters. But the freezing, if you see this freezing ball, so freezing says that the area of the freezing, or like the length of the freezing, is a little longer than 15 millimeters, okay? So with this, actually, we hope that we can use for VTs. Actually, Tom DePotter will show Adagio case late today with atrial fibrillation patient. But this is for VT, and why we assume for VT, because we can reach the lesion depth by multiplication by minutes. So every single minute add to the freezing can increase exponentially the depth. And so it's obvious that within this study we are using like dedicated 3 minutes. Actually, we can deviate, but we use really 3 minutes per application and double. So actually, when you use first 3 minutes, it's about like 8.5. When we add second 3 minutes freezing, we can reach 10 millimeters lesion depth. So this is the movie I will show you. And actually, with the freezing, it's open chest, PIC, and actually the catheter is prominent in the ventricle. And by the time of freezing, you can see and you can appreciate this deep freezing even from endocardial. So what is the hypothesis? So we assume that with deep freezing we can get from endocardium the epi. I will here. Okay, so this is deep freezing getting from endocardial up to the epicardial access. So this is the strategy. This is the CryoCure VT study. I mean, there are several centers involved in the study. Up to now, the study size is like 60 patients. Up to now, we have actually we have like around like 13 patients done, and it involves both ischemic or non-ischemic VTs. Oh, this is, oh, perfect. So this is a number of patients we already done, and it's the summary of the data. I can actually, I mean, guys, our study team allowed to show me. So we have a lesion per patient, and actually it should be, the target is non-inducibility of the VT. So with this, I will leave here, and I will take the mic with me because we will introduce the case. As I told you in the beginning, we have really the guy electively indicated for VT. But in the meantime, when we start to acquire the FAM, actually the voltage map with pentanaf catheter, actually the guy, the patient went to the arrhythmic storming. So we were really not able to stop the VT running. And if you see right now the eyes, and if you can focus on the table with the camera, you might think that we are really crazy, but actually we are not, because we really saved this guy because he was really nearly dying on the table. So we urgently introduced ECMO system, not tandem heart like yesterday. It's like ECMO with venous cannula and arterial cannula with oxygenation. It's the maquette system, cardio help. And actually, with this support, we were still in our patient was in the tachycardia, and it was a very fast VT, and actually we were able to map. Okay, we were able to map. So with this, I would just ask you, Martin, can you show us the first VTs before the cardio help, the ECMO introduction? This is the first VT?
This is VT1.
Okay, the VT1. So actually, I will leave it with you, and actually Toshi or Honza Škoda will continue to explain what they did with this catheter, and actually explain all this imaging they did with voltage, late potentials, and the status.
Okay.
Please.
Thank you, Peter. And welcome to the last case in the morning. And we are almost finished the case, but our case was very complicated. So let me explain everything since the beginning. So you can see the map on the top left. Here's a voltage map, but this was made during VT, because we couldn't terminate VT, and we did so many cardio versions, and finally we found 11 VTs, different morphologies, different cyclines, and we decided to use this ECMO in the morning. Then any VT was not mappable, but after we introduced ECMO, some of those were actually mappable with Pentarray. So let me show the signals with Pentarray on the pulkar. So here's an example. The patient has huge discount anterior wall, anterior septum. And look at the spline 7, 8, 9, 10. You can see the mid-diastolic fractionation. And go to the next one. And this is another example. Okay, so then we introduced the catheter, and we just keep freezing all the way, because we just changed the morphologies but couldn't terminate. So let me show this example.
Změnu těch morfologií tam na začátku, jak bylo. No, a to trošku do té 12. Tam byly ty changes, jo, jak tam měl ten changing morphology, jo.
Go down. Right here. So, this is the one of the VTs we got. So after we started freezing, the morphology changed in the middle of the screen, and then we kept freezing, and then again morphology changed to the other one. Go to the right, go to the right, go to the right. And every time we prolong the cycle length. And actually all VTs were getting slower after each application. And normally one application requires 2 minutes or 3 minutes. It depends on the operator. Well, we decided to 3 minutes application on the same spot 2 times. Then let's move to the last one. Just 5 to 10 minutes ago, when Peter started introduction of this case, let's do the final. Let's go to the final. Freezing.
Tam je vidět do té terminace, no.
So when you look at the map, you can see the 2 purples in the middle of the scar, and my catheter is moving in between. This is the spot. And then, after we started last freezing, right there.
Tady to je ono, a teď doprava pojeď.
Go to the right, go to the right, go to the right.
Termination here.
We terminated the final VT.
Můžeme dát. Okay.
So this is just in the middle of the scar. So let me compile all the story here. We just targeted mid-diastolic potential in the apex, on the basal anterior, and the final application, final freezing was just in the middle corridor, and we terminated the slowest VT. That was the last VT, VT11. So finally, we could manage to terminate or change all the morphologies, all the VTs to sinus. So then, let me show you the catheter as a part of introduction of technology. Please come here.
Petře, chceme ukázat, nechtějí zamrazit třeba? Can you freeze just to test to show?
Hold on. The catheter is bidirectional.
Can we test one?
This catheter requires 10 French sheet via transeptal. And take a look at the catheter tip. You see, the length is 15 millimeter, and the tip has 8 independent electrodes. So let me put it into the water.
Okay.
Right here.
We are freezing now. Okay.
So let's try a test freezing in the water. Now you can see the ice ball around the tip of the catheter. So this means that during application or freezing, you cannot see any signal. So you have to check the signal before you start application. Oh, even my fingers are freezing. Oh. You see the size of the ice ball. It's quite big. We wanted to show the ice ball during application via ice in the live case, but unfortunately the chamber was too big to see the ice ball. So we're showing the ice ball in the water. Now the temperature is minus 133 degrees on the cathedral shaft. And we stopped freezing. You still see the big ice ball around the cathedral.
Are there any questions from the Congress? My question is, we have seen a lot of echo contrast in left ventricle. Is there any pulsatile circulation just now, or if the patient is fully dependent on ECMO, there should be some LV venting?
Yeah. It's not too long time done. It's about 2-3 hours. Now the decision for weaning, I think it's good time today. It will be no problem. The pulsatile action is not there because the VT stopped just 10 minutes ago, 15 minutes ago. So it was all the time in storm, many VTs. So now we stopped, and I think we can get back without any difficult weaning. But of course, you see this with ECMO. This is normal after just stopping all the storm. So the function of LV is now not really preserved, and we need to wait for some recovery after in sinus rhythm.
All right, thank you. And probably if there are no questions from the auditorium just now, so we will switch back. If you agree, we will switch back to ECAN for a summary of the Josef Kautzner case.
Yeah.
Otočte to doleva, hoši, trochu. Okay, you can talk.
Yeah. Can you help me with the orientation of the ice image now? Oh yeah, I see. Okay, yeah.
Pepo, slyšíš mě? Už jsme přepnuli na vás. Můžete nějak...
Jo, slyšíme, no. We actually did this... we tried induction with isoproterenol, and we could not induce anything.
Jak vidím, co jde ven? Ondřej, jak poznám, co jde ven?
Ta velká obrazovka je špatně.
So I'm in. Já nemám sluchátka, nevím, co se děje.
Já myslím, že teď nemluví.
Můžu dostat sluchátka normálně naše, jestli tam v tom...
All right. Can we see Carto screen on or some signals?
Okay, it's your seat. I just wanted to fill up. It was not necessarily. So you just sit down. Yeah, you want a cup of water?
See that you see nothing. Is it so difficult to switch between screens? Can somebody do it? Okay, so you should see, you see that there is small a and big V, and it's fragmented, but we had even better fragmented signals in that area. I will try to find some slightly better. You see that this is the whole area, which is subaortic with some fragmentations, with prolonged stimulus, the QRS. So this is the area where we want to modify this and then try again to induce, but that's all what we can show, more or less, unfortunately. But this is also interesting, I believe. It shows that you have to map, especially in non-ischemic cardiomyopathy, you have to map really very precisely perimitral region and subaortic region, something which I saw from many other places when they send map, they never get this high precision mapping. And this is because with any multipolar catheter, you cannot map precisely this area. I think like you can with a single catheter. So this is very important, and you can really miss such an area of low voltage. You see, it's not very big here, and I think it really fits some of the morphologies, although not exactly as Katja showed you, but this is our now goal to modify this. So if you want to say something more.
No, I think it's a very limited area what you can identify, and it fits with the morphology, so I think it's reasonable to do that and then see how it goes. Because the endpoint is very difficult to determine. You can just simply eliminate this late fragmentation here.
But if you can have intracardiac echo, can we switch to intracardiac echo? You may see that there is aortic valve, pulmonary valve, and there is. Now we were ablating close to this commissure, and there was some whitening. So we are actually doing some modification of this fibrosis, and you can see that it's really like yesterday we saw in anatomical talks. It's some narrow space between pulmonary artery, between outflow tract of the right ventricle and left commissure and right cusp. So we will also ablate probably something in right cusp. You see this area, it's a very packed area, and there is some whitening of the tissue, so it's partly the substrate, partly we did ablation already there. So I believe that this is what we can do for this gentleman. Nothing more is reasonable. So that's it, more or less. Any questions or comments?
I think there are no more questions.
Okay. Thank you very much for your attention.
Very much. And we will switch now to the other EP room at ICAM for Dr. Dhanjal and Petr Peichl. We can see you, we can't hear you. We can't hear you.
You can't hear me. Can you hear me now?
Yeah, perfect.
Can you hear me now?
Yes, perfect.
Yeah, they can, but they don't see you. Now we see.
Okay, excellent. So we have completed the case. Patients left the lab. Just to show you where we left off. So we were in the process of eliminating 2 clinical VTs with targeted deep potentials, which were all green tagged, and we performed a sinus rhythm substrate map, a repeat map to ensure substrate elimination. So in the process of doing the remap, we were looking at elimination of the deep potentials, and if we just flip to the substrate map on the N-side X, you can see that we still had some dark green potentials. The dark green tags are the... So you can see here that we have dark green signals here, which we've tagged. Dark green signals here that we've tagged. Dark green tags here. And dark green tags up here. So 1, 2, 3, 4 additional zones of deep potentials. And I'm just going to show you something really interesting. Can we straighten the map up? In the process of mapping, this region here, where we saw the really crazy deep signals, we didn't see any more deep potentials. But what we did see, and Peter spotted this, Professor Peichl, we saw dissociated activity from the center of this scar. So if we just go to the review electrograms on the Brucker, can you all see, and if you just highlight with the mouse, the lovely dissociated potentials. There we are, the mouse is on it now. So this was nice dissociated signals, and when we were pacing from this region, we couldn't capture the ventricle, so we had dissociated signals there. We did deep mapping, and just to highlight what the deep mapping here looked like, if we go to the deep signal there, sweep speed to 1. Amazing. So you can see the sinus beat followed by the S1 at 600, another S1 at 600, and then an S2 at 380 milliseconds. And after the S2, you see the very late decrementing near-field omnipolar EGM. And this was from this more basal septal region here. And this is what we were looking for with the remap, any other decrementing signals. So we ablated those regions, and we did a final VT stim. And if we show the VT stim, so this is aggressive triples, and from spontaneous VT, 3 different VTs, 2 of them we mapped the isthmuses and ablated them. The other VT probably was using deep potentials from somewhere, just some polymorphic non-sustained VT afterwards. No sustained monomorphic VT inducible. So we were happy with this endpoint.
Congratulations for this wonderful case. Can you hear me? Can you hear me?
Yes.
Okay, congratulations, wonderful.
Yes.
Just a question. If Andrea Natale, who was here, probably he would ablate that dissociated potential. What do you think? Because probably you closed all the entrance in this scar and low voltage area, and somebody can be afraid that one of these entrance can be reconnected. So what do you think? It's better to ablate that dissociated wonderful potential or not?
So my first comment is that there is no clinical evidence that ablating these potentials has any long-term benefit on reducing ICD therapies. So that's the first thing. So this is an evidence-free zone. The second analogy that I see is when we have dissociated PVs, dissociated potentials in the pulmonary veins, we accept this as pulmonary vein isolation. We don't go after those sorts of potentials in the pulmonary veins if they are dissociated. And so because there is no evidence to chase them, we know that from other chambers the phenomenon is an acceptable endpoint. The more ablation you do, the more the risk is of complications. All the methodologies that I am really passionate about in terms of VT mapping is all to reduce the amount of VT ablation that we have to do. Minimizing ablation means the patients are on and off the table quickly, and we know that more ablation correlates with an increased risk of complications such as heart failure from the fluid irrigation, potential for steam pops. So the only evidence for endpoints is VT modified Wellens protocol at the end of the procedure, and in this case we have no sustained VT with aggressive triples.
One more question from Frederick.
Hi, great case, thank you. Can we have a look at all the ablation points on the encytics to get an idea of where you ablated altogether?
So altogether we did 33 minutes of ablation. In a ventricle that the entire anterior wall, the apex was aneurysmal, the septum was scarred. So if you imagine, this is a huge area of scar. And I think with the 20-second protocol with the DiamondTemp time to target temperature, along with focused ablation on functional substrate, I think we reduced this from what could have been 1 hour of ablation to 33 minutes. So this is the map. So remember, we had 2 VTs mapped. This was the isthmus on VT1 and VT2. They involve this region here. And we have, can we put all the green tags to surface, please? All the green tags is where we saw decrementing potentials, and there should be an ablation lesion on every green tag.
Yeah, perfect. So
if there is, we can't do anything about it because the patient has left the lab.
All right, I think
So if we move around.
It was exhaustive already. Thank you again, and we will switch to Milan just now for Carlo.
Thank you very much, Gabriele, Giuseppe. I see the EKG of the patient is completely normalized. Can I have the screen? Okay, Gabriele, Giuseppe, can you comment the results? First of all, the EKG. Can you zoom the EKG?
Yeah,
zoom the EKG.
You see on the ECG we have this flat upper part, which is greatly different from the from the Brugada pattern, and it is quite typical at the end of the ablation procedure for Brugada. At the beginning we were a bit concerned about this, but then it's clearly just something related to the ablation, nothing to do with the problems with coronary arteries.
I have to tell you, Gabriele, that this elevation is very specific for Brugada ablation. Because when we ablate in the epicardium, early repolarization, long QT, we don't see this elevation, but it will be completely normal tomorrow morning.
Yeah. So the abnormal potential area was quite large, 27 square centimeters. You see there. Can you see the map?
Can you say about the maps?
Yeah, you have in the lower part on the right, the Carto screen, you have the comparison because Gabriele already, after having performed the ablation, we have performed the epicardial mapping right away after ablation. You see on the right side the purple area, which is the substrate analysis, accounting for 26 square centimeters. So it was a quite big area of abnormalities, but we expected that after Ajmalin. You saw with this big reaction after Ajmalin administration with a type 1 that was accounting for all the leads in the high right precordial leads. So we expected that the substrate was going from the higher part of the outflow tract to the lower part.
Can you show the present electrogram?
Yes. Can you show the electrograms on the decanav catheter?
Okay,
just the right side. The right side.
Okay, perfect.
Okay, this is the live electrogram recording. So you see the decanav is exactly in the area of ablation where Gabriele ablated.
The localization of decanav on the same point. So this means that we did not ablate transmurally, right, Giuseppe?
Right, and most importantly, I think that is the goal of the procedure is to get rid of all the late activities that we had encountered at the beginning. You see also that we are ready to perform Ajmalin.
Start the Ajmalin.
So it is a very important aspect, as you know, and I think you want to comment about that. Of the repeat.
The Ajmalin is extremely important because if we left even a very small region without the elimination of abnormal potential, we can see, in according to the localization from V1 to V6, the type 1 again. So if we zoom the EKG during infusion, we can see if we still left something. In this case, we do the remap again under Ajmalin, and we just reablate that particular region. Usually, the recurrence of the abnormal electrical activity show the map. Usually the recurrence is in the inferior part of the substrate. Mi fate vedere la mappa per piacere? Okay. Can you show with the arrow? Usually we have the recurrence in this region, but we already know. So we are ready to do something in case of recurrences there. Giuseppe, Gabriele, do you have an idea of the reason of this? Can you inject some water in the pericardium? Because I see the cut.
Well.
Okay.
No problem. Because at the beginning, at the end of the procedure, we left some water inside just to make sure that we could move freely. Why it recurs caudally, frankly, I have no idea. Interesting, this is the same experience of other operators. So
but no
I
problem.
think that
Just
probably,
1-2 centimeter of lesion again. But
yeah,
probably in this case, we don't see anything. How much you gave of Ajmalin?
Almost 20 milligrams. Just to remember, we had 25 milligrams of Ajmalin at the beginning, so we will do exactly the same.
Okay.
And you see that the reaction was quite remarkable. I see that.
So this is a large area, and we had to ablate. Our radiofrequency time was 19 minutes.
Can you zoom the EKG? Zoom the EKG, and then, okay, perfect, no pattern. Can you zoom the electrogram to see if we prolonged the activity with Ajmalin? No, nothing. Very well. Important, we preserved the transmurality, see? Very good.
Yeah.
Can you
Carlo,
move the catheter to the left, Gabriele, just to see if we have something to the left in real time? So the electrogram to the left is still very normal. Can we see the voltage before the ablation?
Okay.
Yeah.
We have finished the dose, Carlo. Carlo? Can you see me?
Yeah.
We have finished our dose, so...
Okay, perfect. Very good. But we want to see in detail the voltage before and after.
Yeah, sure.
Just to clarify that we did not destroy the right ventricle. This is essentially important. We won't just modify the superficial layer. This is a very superficial lesion. So the voltage after doesn't show any particular modification of the voltage. And after this, we usually do the electrical stimulation.
Yeah. I want to acquire the map now to make sure that it was a very large area, so we have to make sure that we eliminated everything.
Yeah.
It will require a few minutes.
There is nothing,
but I
Gabriele.
believe,
Unfortunately, we don't have anything more. And we don't have recurrence below, so you have to stop your ablation attitude.
No, but I am just checking, you know.
Yeah.
I want to make sure. I don't want to leave anything.
So very good. I think we taken too much time. It is a successful case, and we demonstrate everything. You have to add something more, Giuseppe?
No, I think that the end point of the procedure is quite clear, and especially in those cases with a severe phenotype and a severe clinical presentation. So we know that we don't want to leave anything left in the epicardium and to eliminate all the late activity, and I think this is the case. So I think that we...
And is negative to the Ajmalin infusion, so it's a confirmation that we eliminated everything. Now we infuse a little corticosteroid, right?
Yeah, right in the epicardium afterwards, after the procedure. So typical, our standard approach to infuse corticosteroids inside the pericardial sac. And the patient will undergo, at the discharge, will colchicine and NSAIDs just to avoid any pericardial reaction afterwards.
Okay, thank you very much, Gabriele. Giuseppe, congratulations. Thank you to the audience. Thank you, Joseph.
All right. Homolka. No. I don't know. So maybe...
Is there any question from the audience? Too late? I don't know. Can we connect? There is one question for Milan. Can we connect Milan?
Are we live?
So, are we live? Okay. So, welcome back to Homolka.
It's disconnected.
Do you hear us? Okay.
I'm here.
Okay, there is one question, Carlo, for you from the audience.
Thank you for a great presentation, and it was nice. So, my ask is how to do that. Let me know about the settings for superficial ablation, the time and duration, and the AA guided. Would you like to have that?
Yes. First of all, we use 50 watts. We stay on each point between 5 seconds to 10 seconds in according to the resistance of the abnormal electric. We do the very fast navigation. We came back to the same point if we see the persistence of abnormal electrical activity, but usually it's sufficient 10-second lesion, 10-second application. Because once again, we don't want to be transmural. It's not necessary. And with this type of application, we just remove the late activity, and we don't change at all the voltage of the potential. Did you see the voltage map after this case? Is pretty equal to the baseline voltage map. This is very interesting because, as you know, also from the Braunwald, we have to admit that most of the diseases are localized in a very specific layer of the myocardium. We should not be surprised that the cardiogenetic disease decide to be in the pericardial cavity. This is not a myocardial infarct. Myocardial infarct involves the entire wall. This is an example of a specific localization, genetically codified, of a substrate. So it's not necessary to be transmural.
Okay. Thank you, Carlo. Thank you so much. We have to move to Omolka to close the other two cases. Bye. Thank you. Can you hear us?
So we are live back again.
Connected?
So can you hear us, guys?
Yes.
In the audience? Can somebody hear us, please?
Yes, we hear very well, and we see you. Perfect.
We don't have any response, sorry. So can we continue?
Okay. Can you hear us?
Excellent.
We can see you and we can hear you.
Okay, perfect. Thank you. So let us show. We would like to show now what we have done so far. So from the beginning, from the pericardial axis, we finally did transeptal puncture to the left atrium. We did one puncture with one hole, and we introduced two sheaths inside. Then we did with the HD grid anatomical map of left atrium. So we can show you maybe now how does it look, the endocardial MAC and the beginning. So we did anatomy, voltage map, and activation map, and we found that because I just want to remind you that this is the redo case. So we revealed there is one gap in left superior vein. Other veins were still isolated, and also what we found that there is a gap on both lines of box. So it means even the roof line and inferior line. So at the beginning, we did just re-isolation of left superior pulmonary vein. So we did some application on the ridge, but finally we found the gap on posterior carina. So if you want to continue, Sean.
Yeah, so if you just look at the right-hand map for the moment, you can see, can you synchronize the maps? Actually, I mean, they need to be big so that they can see them in the room. So
just one screen?
Just one screen, please. Yeah, maybe how you were before was fine. Okay. I mean, they're roughly both PA. Put them both PA. Yeah, okay. So on the right-hand bit there, you can see, on the epicardial map on the right, you can see that the oblique sinus is that bit that's been circled now. And you can only get up to the top of the roof of the left atrium there. There's a bit that's unmapped, which is the horizontal pericardial folds. You can never get there epicardially. But coming around, if you go to left lateral view on both, yeah, that's good. That's good. So yeah, you can slide into the transverse sinus on the epicardial map in between the left upper and the appendage, and then let's go to an anterior view. And tilt down. And then you can see we've mapped the anterior wall via the transverse sinus epicardially with the HD grid. Now, in this case, we've decided to simply redo the veins and box. But if one wanted to do an anterior mitral line, for example, then the transverse sinus on the right is where you would be doing the ablation. If you just go to the right-hand map with the cursor, the right-hand map. Never mind. Just go back. Yeah. Anyway, you see where the dark blue is on the left. That is sort of Bachmann's going towards the right atrium there, and then towards the right where it says isolation on the map. That location there by the left atrial appendage. So Bachmann's would be going straight across there. So if you were to do an anterior mitral line, it'd be somewhere in the middle there. So. If we can we show the interesting signals from the epicardial inferior line?
Yeah, so can we have on Broca screen?
Or we could go to the epicardial map on the X.
Okay.
Yeah. Yeah. So yeah.
But maybe we have it on Navex screen. So can you show me maybe on Navex screen? So let's go back with Navex, please. Okay.
Not those ones. Not those ones.
Big difference. Okay, this one.
Yeah, this signal here. So yes, if you look at the blue grid signals here, there's a sort of complex signal. So we did some ablation there, just by the right inferior, and endo and epi, and we blocked the inferior line in this location. We did a series of remaps of the back wall, and then I did an endocardial roof line, and now we have block, basically, don't we?
Yep.
So we can show the last endocardial and the last epicardial map, just to show block on the posterior wall. That's the endo map. Yeah. Yeah. We've not done any roofline ablation to the epicardium, but I think I will just go there now in a minute and just do one or two lesions there, just because the patient has had a recurrence of the roofline already. So since we're here, it probably makes sense to do a couple of epicardial lesions there. If it's interesting, actually, this roofline is only approachable via the oblique sinus. You can't approach this roofline by the transverse sinus because it's too posterior. And this is something we've been looking at, but if you were to place the roofline more anterior such that you could reach it by the transverse sinus, the box gets about 50% bigger, and that may or may not be good for patients. We'll have to see. So I think that's where we are.
So do we want to induce maybe, or do you want to introduce the ablation catheter into pericardial space and to do some more applications there in the roof?
Yeah, why not?
Okay.
Okay, so that one out.
Okay. So I just want to highlight that there is no any blood still in the pericardial space. There is nothing, so it's clear. And now we are introducing.
And the only temperature rise that we've had was from ablating near the PVs, wasn't it? There was nothing from any of the other ablation. So just tilt the map.
So we are epicardial now with our ablation catheter.
Tilt the map a bit. No, I just need. Yeah, okay, that's fine. So I'm trying to get. Could you tilt the left-hand map up a bit, please? No, other way, other way. Sometimes it can be tricky to navigate around the atrium epicardially, because obviously you've got all these sinuses everywhere. And sometimes it's helpful to put a bit of saline in if you're really getting stuck. That seems to be going into the oblique sinus. Now tilt down. Okay. We'll be pushing up against the horizontal pericardial fold here, so just need to be careful of high impedance and potential pops. Is the vector going in, please? Is the vector pointing inwards? Can you just tilt?
No, not yet. Now it's better. Yeah.
Okay.
Pointing, yeah.
50 watts, 10 seconds. Obviously important to have the vector pointing in. You don't want to be causing pericarditis. Okay. Another lesion? This is about as far as up as I can get, yeah? So I can't get any closer to the roof. You can see on the right-hand geometry, that is the limit of the oblique sinus. So if I wanted to do more epicardial ablation, it would have to be via the, okay, RF on? It'd have to be via the transverse sinus, or just more power from endo.
Could you change the color of ablation of signals from ablation catheter, because we can't see at all?
You mean on Bruka?
On Bruka, ablation electrograms.
Změnit barvu ne zelený, ale nějaký jen světlejší jako ablační. Na pruce. Oni nevidí jako tu zelenou barvu.
How can you identify nerves there? I mean, we had one case with gastroparesis, and I'm quite concerned to identify those structures which are critical in the epicardial space, especially in this area. How do you do that? And
yeah, I mean, I'm basically just pointing the vector in, as you've seen, Fred, just trying to make sure that we're done, actually, to make sure that, I'm ablating towards the heart. You're quite right. I mean, that is one of the risks with RF, wherever we are in the epicardial space, is that we're ablating in the wrong direction. Yeah, we've done it. We've only done 4 lesions there or so. So I think we're done.
Yeah.
Yeah.
Yes.
We can put carboxyl in the pericardial space to take. There is one more question. One more question from Boris.
I think you addressed it. Would it make sense to inflate their carbon dioxide to protect the esophagus from heating up? Yeah, that's a good point. Yeah.
So we have the, if I can screen, we have the temperature probe. The ablation catheter has moved now, unfortunately, but where we were was quite a long way from the esophagus based on the Circa probe. So we've not really been too concerned in this particular case because the esophagus seems to be quite towards the left. In fact, it was the ablation on the left veins that caused the temperature rise of the esophagus. But I think to answer your question, it would make more sense possibly to put saline in, and that's something we've done in our lab. Particularly, you could put 50 mils of saline in, for example. I think that's more likely to be protective of the back wall. And then putting balloons in as well has been published as mechanism of displacement. So I think any of these things are likely to work. As it happens, today the esophagus is not an issue for us.
Mm-hmm. One more question about pericardial puncture with carboxide. Is it possible to inflate carboxide through the right atrium instead of coronary sinus branches? Is it possible? What do you think?
So it is definitely possible. I've done it many times myself. So there is data published on right atrial appendage exit. If you exit in the apex of the appendage, right atrial appendage, it's not a bad place to exit the heart because it's a low pressure area, as are the coronary veins. What I would just say about that is the right atrial appendage is much thicker than the coronary vein. It's harder to perforate. You do need more support. And particularly in patients who've got dilated atria, like the ones we're often dealing with, that can add another complexity to right atrial appendage exit because to get support, you have to push off the back of the wall, going towards the front wall. And yeah, so the more dilated the atria, the more tricky it becomes. Yes, to answer your question, it can be done, and it's not particularly difficult, but I think it is harder than what I've shown today.
Thank you. Thank you. Is there any more question from the audience? No, if not, we are perfectly on time. Wonderful. So thanks a lot for this wonderful case, and we can go for coffee break for 15 minutes. Thank you.
Thank you very much. Bye, everyone.